Okay, dear chairperson, dear colleagues, it's a privilege to be among you, and I would like to thank Jan Reginald for his kind invitation. Now, let's see. Here you already heard about the speakers. Is Sabena Sultan and myself. I'm working in the Aristotle University of Thessaloniki. This is my city, and this is the hospital where I'm working the last 30 years. I'm here because I believe strongly to this statement, and I think research is the answer for this kind of orthopedic conditions. Let's see the objectives. I will try to discuss with you the next 20 minutes what is a tennis elbow, the anatomy of the tennis elbow, and which tendons are affected, and how we can recognize the condition and how it's going to be treated. And lateral epicondylitis, or tennis elbow, is a tendinitis or tendonitis. I prefer this term. And it is in tendonitis an inflammation or irritation of the tendons due to overuse. So athletes, musicians got quite a great prevalence of this kind of condition. And believe me, if you got tendonitis, it hurts. You've got a lot of pain. You cannot do almost nothing, as I'm going to show you later on. And you can get tendonitis all over the body, okay? From the shoulder to the foot. Wherever there is a tendon, we can get tendonitis. And I told you already that it's an overuse injury, because if you stress the tendon beyond the physical limits, then you are in trouble. And what are the general signs of tendonitis? Is pain, pain, pain. And if you've got pain, then you've got less strength, less range of motion, muscle dysfunction, and so on. What about the elbow tendonitis? Because we are going to treat the elbow tendonitis. You've got the medial one and the lateral. And the lateral is our focus, is the tennis elbow. So you can see here is the medial epicondyle, and here is the lateral epicondyle. And we've got this bone prominence, because from the lateral epicondyle, we've got the attachment of the common extensor tendons, those who are doing the extension of the fingers and of the wrist. In contrary, from the medial epicondyle, we've got the flexor muscles, who are doing the flexion. Okay? And this is why we are calling the lateral epicondylitis tennis elbow, because 40% of the tennis players are getting with this condition. In contrary, the golfers who are using the flexors, who are getting with the medial epicondylitis, it's much lower, the prevalence. I'll show you later. Let's focus now on the lateral epicondylitis, the tennis elbow. For the general population, the prevalence is 1 to 3%. And most commonly affected the men and women of the 4th and 5th decade of age. Why is that? Because there may be some degenerative changes of the tendons. And this is why this midlife group is more prone for this injury. And as I told you, the medial epicondylitis is much less. So, which is the etiology? You already heard how about the smoking from the previous speaker, obesity, the repetitive movements, and the forceful activities. And all this showed a significant association with the lateral epicondylitis. Who is to blame for? This is the 4 tendons originated from the lateral epicondylitis. But you can see that the extensor carpi radialis brevis is the key player for the wrist extension. It centralizes the extension of the wrist, because it goes from the lateral epicondyle down to the base of the 3rd metacarpal, who is the key point to do a centralized wrist extension. And they found that this is the one tendon who is getting the problem. What are the symptoms? I told you, pain, 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 before, during, and after the activity, on palpation, or if we are going to grasp or squeeze some things. And sorry about this busy slide, but what I'm trying to tell you is that there are some phases of developing this disease. The main thing for the clinicians and for the researchers is to stop this disease at this level. Now, if you got after the phase 4, then phase 5, 6, and 7 have increasing percentages of permanent tendon damage. And what's the problem? Then you've got with a refractory tendonitis, which requires surgery, almost to 10% of the patients. The recovery from the surgery takes a long time, and the rate of success is 80%, not that much. So, what are the treatment options for the tennis elbow? Look at them. Too many. Rest, splinting, injections, plasma injections, platelet-rich plasma injections, allogenic mesenchymal stem cells, surgery. Too many of them. Examples, you can see how we can do the cortisone injection, the splinting. This is wrong one. I prefer this one. Do some exercises to stretch the muscles. Do an open or arthroscopic surgery for the tennis elbow. And if you go to the puppet and hit tennis elbow treatment, you will end up with almost 1,300 results. Too many. Something is getting wrong. So I picked up only this paper because I like the title, Tennis Elbow No More. They are claiming that with exercise they are getting good results. Not that true. So what about evidence-based medicine? You will see that there is some support for the topical anti-inflammatory drugs. There is insufficient evidence for the oral anti-inflammatory. And the injection may be more effective than the oral one. And about the surgery, no published controlled trials. So let's hear to the patients. What about the sufferers? The key question of them is, how long does it take to heal? They have developed a website, a classroom to discuss their problem. And look, 6 to 12 months, 1 to 3, but recurrences are common, plus 2 years, and so on. So, now Sabena Sultan will tell you how we have solved the problem of the tennis elbow. So, tennis elbow no more. Thank you.
Hi, okay, so I work for Cell Therapy Limited, and we worked with the clinical team in Greece under Professor Givissis. And really what we were trying to do at Cell Therapy Limited was to look at and develop a regenerative allogeneic patented gel. And the reason we were doing this was because platelet-rich plasma and platelet-activated gels have shown to be effective in soft tissue injuries. So about 4 years ago, when I joined CTL, we were trying to develop this gel. And this gel is a unique combination of growth factors, which is embedded within a cellulose derivative, which allows you to give a controlled release of growth factors and allows you to give a maximal therapeutic benefit. So we were interested, after we developed this gel, to work with the clinical team to help people who were suffering with tennis elbow. So we set up a double-blind, placebo-controlled phase 2 trial. And the name of our gel is Tendoncel. So we were interested in investigating the efficacy and safety of Tendoncel in lateral epicondylitis patients. We had 30 randomized patients, which half of them had Tendoncel, the active treatment, and the other half had placebo gel. So this was a cellulose derivative without any growth factors. These patients were then applied the gel topically with an adhesive dressing consecutively for 21 days, and then they were followed up at 4 weeks, 6 weeks, and 3 months. We were recommending that both the placebo and Tendoncel patients to undergo an exercise regime which would allow them to strengthen their forearm and their wrist. So the endpoints of the study, really, we had 2 primary endpoints. The first was a questionnaire, the Disabilities of Arm, Shoulder, and Hand questionnaire, which is a 15-point questionnaire which allows you to assess pain and function of the elbow. And the second was the patient-rated tennis elbow evaluation questionnaire, which is a 38-point questionnaire, again looking at function and pain, and you rate your pain between 1 to 10. So the higher your pain, the higher the value. So these were our sort of primary endpoints. Secondary endpoints really were looking at safety. So we wanted to see whether there was really any systemic effect of the gel to our patients. So we took regular blood samples to check immunoglobulin E levels to see whether these were sustained. And secondly, we looked at safety, where we were looking to see whether there were any cutaneous reactions from the gel. So the inclusion criteria of these patients, really, they were generally healthy, 18 years and over, and they had a confirmed diagnosis of grade 3 lateral epicondylitis, which was confirmed using the Cousins test, which is a functional test, which allows you which basically is a resistance test on the tendons of your muscles and how well you can resist that. And there was an extensive exclusion criteria, which I won't read through and bore you with. But so the study schedule really started with 6 treatment sessions. The first was a screening session, so we went through inclusion, exclusion, consent forms. Patients were their DASH and PRTE questionnaires were taken at baseline. Blood samples were taken to establish what their baseline IgE levels were. Photographs were taken of the tendon before and after gel application. A stretches and exercise program was taught to each patient, and they were followed up. So when they came in for screening, we had a patch test just to be sure that there was no immediate adverse reactions. So that was for 48 hours. And then they came back into clinic. We checked whether they had really understood how to do their stretches and exercises properly, and checked whether they had any problems. Once they were okay, the sign-off was given by the clinical team. Patients were given gel kits to just take home. So this is a topical application. They had everyday packs. They just had to apply the gel, put an adhesive dressing on the top, and note any problems that they had. And then they were followed up to 3 months. So really now we're going on to the results. So this graph summarizes the disability of the arm and shoulder score, which I told you about earlier. This is comparing, so these are the placebo patients and these are the Tendoncel patients. So these are their baseline scores all the way up to 3 months. The first thing I would say really is that there's no statistical difference between the control and test at baseline, and that there was a statistically significant decrease in DASH score at each follow-up time point. The p-values are comparators of control and Tendoncel at baseline. So there was a statistical difference. The second endpoint was the PRTEE score, and again, very similar results were seen all the way to follow-up. There was a decrease in score values. The third endpoint, which was safety, we looked at IgE levels. These were all normal. Some patients did present with higher IgE levels at baseline, but this was always lower in the Tendoncel group compared to control group. In terms of safety, there was a transient red discoloration of the skin in 23 out of the 30 patients. But this was really due to the adhesive dressing and not due to the gel. So in conclusion, Tendoncel is a novel, allogeneic, regenerative, topical medicine. It's both efficacious and safe in the treatment of severe tendon injury, lateral epicondylitis. So it just leaves me to thank the clinical team and the CTL team who were in lab base. Thank you.
There appears to be a strong placebo effect as well. The placebo went down quite considerably in the group. Now, were there significant differences between the placebo group and the treatment group at the different
At each time? No, there wasn't. No.
So there's no effect. So how did you work out your efficacy?
No, hang on. So I think the question is there a difference between the placebo group and the active group at each time point?
Yes,
the answer to that is yes.
Yes.
That's the statistical significant difference.
Yeah.
Don't forget that all of them, they were doing exercises, so they will get some improvement, but not so much as the Tendoncel group. That was significant. Okay?
So each patient was having physio as
Yeah.
well as treatment.
Yeah.
All of them. But half of them had the Tendoncel, the gel.
Yeah.
So what is your mechanism of action? Do you know how it works? Is this,
We have a hypothesis of, we've identified the main, I would say, 5 growth factors within our gel, and we are deducing what as you can imagine, the possible mechanism could be. But we're still going through our analysis. But it's the 5 key players that we've got. It's the VEGF, TGF, PDGF. So it's a complex interplay of those growth factors that is working towards this sort of healing.
Sorry, yeah, go ahead.
My question is actually related to her question. But is this a natural product, or do you have some other synthetic?
No, this is completely, it's completely natural.
It's completely
Yeah.
natural. And where did you get this? What's the source? Is it animal or human being?
So it's human allogeneic platelet lysate. So these are platelets that have been taken and have gone through a sort of proprietary mechanism to release these growth factors that we've sort of identified and keep within a very stringent and defined concentration range to know exactly how they work.
So you have a form, some kind of a standardization, because obviously if you get this from
Yeah.
patients,
There's everyone's, yeah.
there's a certain
Yeah.
deviation.
Yeah, of course. Yeah, you'll have natural deviation. Yeah, of course. Yeah.
I think it might be worth just talking about the Cochrane reviews. So there's 2 Cochrane reviews which are worth looking at. One Cochrane review looks at platelet lysate, specifically in lateral tendinitis and also in tendon injuries. The second Cochrane review looks at all topical agents for lateral epicondylitis. Both Cochrane reviews find no efficacy at all. For platelet lysate, you can look at Cochrane reviews. For autologous platelet lysate, you can look at Cochrane review for broader tendon injury, and again, you find no efficacy. So what's interesting here is exactly your point. The uniformity and the unique preparation of the gel plus the lysate is producing an interesting benefit, which, to your point, is above and beyond just physiotherapy. So each patient is compared active with physiotherapy versus control with physiotherapy. And I think the team thought that was important because physiotherapy does show a benefit.
Yeah.
So physiotherapy in double-blind placebo-controlled trials shows a benefit of about 10%. So what you're seeing is a benefit above and beyond standard of care.
A couple of things. First of all, I deal with oncology clinical trials, and to show a modest benefit, and I think we're talking here about a modest benefit, you generally require hundreds or thousands of patients. So I'm deeply sceptical of a trial, a randomized trial of 30 patients. It's just the beginning. But what I wanted to ask you is, do you have any evidence that these growth factors penetrate the skin? And secondly, why did you look at total IgE as a safety parameter?
Do we know, so sorry, the first question was, do we know if these growth factors penetrate the skin?
Yeah.
Yes, so we've done quite a few functional assays within the lab to look at the life of these growth factors, to see how they interact, looking at fibroblast assays, the best in vitro assays that we can have in our lab to be able to assess whether they do penetrate the skin. I mean, there's a lot of evidence to say that they do penetrate the skin. The functional assays that we've looked at shows proliferation, migration of fibroblasts, as well as looking at conditioned media. So we've done the sort of general preclinical screening, if you like, of the platelet derived growth factors that we have isolated and that are in this gel. Why did we look at IgE? That's what we thought would be the best way of checking whether there was a systemic reaction. I don't know, would you have any thoughts on what would have been a...
Yes, I mean, just systemic levels of IgE are very variable in the normal population, especially with people with atopy and so on. So total IgE, I think, would be unlikely to change as a result of this therapy. Secondly, usually when we do trials of biologicals, we look at human anti-mouse antibodies, or HAHA, human anti-human antibodies and so on. They usually look at IgGs and look for something specific to whatever it is that you're administering. And I've never seen IgE evaluated as part of the safety testing for a therapeutic protein. I may be wrong, but that's just my...
So what would you look at for the source of Ig? You're saying you would look at mouse or...
No, so let's say, it induces the growth factors that you're using that are penetrating the skin. You'd have to look for a specific antibody response to those.
But how would you do that if it was a complex of growth factors?
Well, use the drug itself as your target antibody.
Yes. I mean, but it's just that total IgE varies so much in healthy people anyway. And I was intrigued that you've done that. I've never seen that looked at in any therapeutic protein trial.
You see often IgE used as a readout for skin applications.
Perhaps that's
More than systemic is often IgG, but usually you do an anti-drug IgE response, so look for titers against your drug.
It's very helpful feedback.
Okay, yeah, that's good to know. Thank you.
Is there any other questions? Yeah, please.
Can you tell us something about the manufacturing requirements? Do you have GMP license or?
So we're going through our sort of GMP and manufacturing license processes at the moment. This is a gel that we've developed completely in-house. So we've done all our sort of quality control checks that we can do, and we're in the process of getting our GMP and manufacture.
But is the clinical trial possible to run without the IMP produced, without the license?
So for the phase 2 that we've conducted, we had ethical approval, obviously, for the trial. But we don't need, with the National Organization of Medicine, which is the regulating body in Greece, you don't need to go through GMP manufacture until you hit phase 3. So we're going through that process at the moment.
What do you think was the reason of loss of pigmentation of the skin while using this gel?
It was literally just because some people are sort of have a slight allergy to the adhesive dressing. As soon as they stopped using that particular adhesive dressing, it went. So it wasn't actually related to the gel at all.
It's transient, right?
Yeah, it was transient.
We are over time. Shall we take a 5-minute break before the next presentation? Because we've run over a couple of times. We start the next one at